Good morning, everyone. Thank you, Mr. Chairman. Let me first thank Patrick Marcelin for the invitation to this important meeting. I would like to be with you next year. These are my conflicts of interest. Well, the peculiarity about NAFLD is its wide global prevalence worldwide, an estimated prevalence in 25% of the general population. So NASH, the progressive form, can be found in 10 to 20% of people with NAFLD, meaning up to 6.5% of the general population. And advanced fibrosis and cirrhosis can be found in 10 to 15% of people with NASH. Modeling shows a slow growth in total cases and a greater increase in advanced cases. So NASH prevalence by 2030 will increase by 15–56% depending on region. So China will experience the greatest overall increase of patients with NAFLD, while in the United States there will be the fastest rising incidence of decompensated cirrhosis. And liver-related mortality and advanced liver disease will more than double. If you look at the global mortality burden of NAFLD and NASH, we know that in NAFLD, the first cause of death is cardiovascular, and the incidence of cardiovascular mortality is definitely higher compared to the liver-related mortality. But if you look at NASH and you look at the incidence rate per 1,000 persons a year, you see that liver-specific mortality is increasing from 0.77 to 11, all-cause mortality from 15 to 25, and HCC from 0.44 to 5.29. The clinical outcomes vary with the stage of the disease. So if you have NASH with bridging fibrosis, the clinical events are dominated by cardiovascular disease, first cause of death, followed by extrahepatic malignancy. However, there is also the threat of HCC in non-cirrhotic NASH. But when you go to cirrhosis, definitely the outcomes are liver-related death, hepatic decompensation, and again, most importantly, hepatocellular carcinoma. Fibrosis is the best proven predictor of liver-related mortality. On your left panel, you see a seminal study from Paul Angulo, where he stratified the patients according to the presence of NASH without fibrosis, the upper lines, NASH with fibrosis, and you see the different cumulative survival between the two populations. These results have been confirmed in the following years. For example, this is a retrospective Swedish study in patients with biopsy-proven NASH that were stratified by fibrosis stage. And compared to the general population, which is this red line, patients with F0 and F1 have similar mortality, while the proportion alive decreases in F2, F3, and definitely in F4. This is a meta-analysis of 5 multinational cohorts. You see there is a slight increase of all-cause mortality rate ratio by fibrosis stage, but definitely an exponential increase of liver-related mortality rate ratio by the stage of fibrosis, going from 9.6 in F2 to 16.7 in F3 to 42 in F4. What is the fibrosis progression rate? This is a meta-analysis of 11 pair biopsy studies, including 366 patients with NAFLD that were subdivided into patients with simple steatosis and patients with NASH. In 36% of these patients, there was a progression of fibrosis, 46% remained stable, and 21% had an improvement. But the rate of fibrosis progression was different. In simple steatosis, there was a progression by one stage of fibrosis over 14 years, while in NASH over 7 years, so half. However, in 21% of patients with baseline stage 0 fibrosis progressed to stage 3 or 4 fibrosis over a mean follow-up period of 6 years. So there is definitely a substantial variability in fibrosis stage, and this is a lesson that we learn, for example, from the placebo arm of some study. This is the phase 2b CENTAUR study. These are the results after 1 year, and the change in fibrosis stage. You see that 35% of the patient worsened their stage of fibrosis, 45% remain stable, and 20% improve. But over the following year, 80% of those who had improved in the first year worsened, 27% of those who were stable in the first year improved, and 53% of those who had worsened in the first year improved. So at the end of the second year, you have similar proportion, but definitely these are not able to describe the change in the natural history. And indeed, there is a substantial interpatient variation in disease natural history, rate of disease progression, and outcome. So you can see a first dynamic steatosis and steatohepatitis phase, followed by a non-linear fibrotic phase, where you can either progress or regress, particularly in the early stages, where regression is definitely more difficult in F3 and definitely in F4. And there are a number of environmental and genetic factors that can influence the progression on NAFLD, from gender, ethnicity, but also genetic variants such as PNPLA3. Lifestyle is definitely very, very important. The Western diet, the high fructose intake, the reduced physical activity, but also comorbidities. And we know, for example, that type 2 diabetes and hypertension are two well-proven clinical predictors of worsening of fibrosis. So this slide summarizes the natural history of NAFLD, which is not a smooth transition from simple steatosis to NASH to cirrhosis, but it's a dynamic state with fibrosis and all the liver damage that wakes and wanes. And you see 12 to 40% can progress to simple steatosis, from simple steatosis to NASH without severe fibrosis, 15 to 43 to NASH with severe fibrosis, and 38 to 50% to cirrhosis. However, there is the possibility also of regression. But also there are rapid progress. So you see 8% can jump from simple steatosis to F3 fibrosis, 8 to 6% can jump from mild fibrosis to cirrhosis, and 1% can go from simple steatosis to cirrhosis in the same lag time. On top of that, there is the onset of hepatocellular carcinoma in cirrhotic NASH, which is estimated 2.3% per year, and in non-cirrhotic NASH, 0.6% per year. Once patients have bridging fibrosis, this may progress faster to liver decompensation. And this is the time for first 10% of patients to develop liver decompensation by fibrosis stage. You see that patients with NASH who have bridging fibrosis or cirrhosis may progress to liver decompensation in as little as 4.3 years for F3 or 1 year for F4, respectively. And another lesson that we learned from the CENTAUR trial, which was a negative trial, is that over 2 years, 25% with NASH and bridging fibrosis may progress to cirrhosis, and 20% of cirrhotic patients may have liver-related events. And again, the increased risk of liver events is predicted by the worsening of fibrosis by Ishak stage, collagen content of the ELF test. So it is not a surprise that liver transplant due to NASH is rapidly growing in the United States. You see from 2002 to 2018, NASH has become the first reason for liver transplant listing. And the same is true also for liver transplant listing for hepatocellular carcinoma. We have a problem, although, with hepatocellular carcinoma. And you see from the survival course of patients with HCC that the survival of patients with NAFLD is definitely lower from the diagnosis of hepatocellular carcinoma compared to hepatitis B and hepatitis C. And among the factors associated with 1-year mortality, there are older age and stage tumor and NAFLD with an odds ratio of 1.21. And this is mainly due to poor surveillance, which is due to the enormous burden of the people with NASH, as well as the presence of HCC also in non-cirrhotic livers. So my conclusion is that NAFLD is a complex disease with pathogenesis and progression determined by a combination of genetic and environmental factors. The natural history of NAFLD and NASH progression is much more dynamic than has been previously appreciated. And the factors leading to the progression of NAFLD are only partially understood, a limitation that is particularly serious by considering that up to 40% of HCC cases occur in non-cirrhotic liver. Certainly, genetic factors may be one component of these processes. However, we need large cohorts and detailed multi-omics data set to provide insight into these processes and help us to identify robust stratifiers. And I thank you so much for your attention.